Okay.
So 4 people are online as of now, and to early bird entries, I think Pranav Verma is saying good evening. Hello, Dr. Pranav. Good to see you online. We'll begin in few minutes. Those who have joined online on YouTube, all of you are welcome. You can just say few hello things so that we know, and we can take your name and wish you personally good evening. Those who have joined on YouTube, please say something in the comment section.
I think majority will join in YouTube.
Yes, sir. This link is with you and me only. So only option available for people is to join through YouTube only, and that is the format of our webinar basically. So people are joining in. It's exactly 7 o'clock right now, and we will wait few more minutes, and then we'll start, sir.
Okay, okay.
So few more people have joined in. Dr. Priya Singh is saying hello, good evening, sir. Dr. Pradeep Sharma has joined. Good evenings. Dr. Rajendra Lalani from Gujarat has joined. All of you are most welcome, sir. It's privilege to have you as audience. And hopefully the COVID pandemic, which is already on the wane, doesn't rear its ugly head again. And vaccines are available for all of us earlier than later, so that we can meet each other personally. So we'll just wait few more minutes before we start. Pranav Verma is saying background sound is there. I will. I don't think my cabin is having any background sound. Dr. Mondal, can you check whether any something is rustling, some papers are rustling at your end, or some noise is there?
No, there is no noise.
There is no noise. Are you using headphone or something?
I'm using headphone.
Actually,
I'm using,
if your laptop is good, there is no need of anything, because that usually creates the interference. Dr. Manoj Kahar, always a very enthusiastic member of PathoIndia and all the online forums. Great learner and great teacher. He is also here. Looking forward to learn from our respected Dr. Asitava Saab. He is saying. Uh, Dr. Shamim Akhtar Mimi has joined. He's saying good
from
evening.
Bangladesh.
He's from
He's from
welcome, sir.
Bangladesh.
Welcome, Dr. Shamim. So Neelam Srimani ma'am has joined. She's saying hello. Abhigyan Srivastava is saying good evening. So all of you are most welcome. Just wait 1 or 2 minutes. So all the people who have joined online, please say something so that we know you are there. Dr. Manharlal Dadania is saying good evening, Dr. Mondal sir. So Dr. Mondal, you have a very big fan following, including myself,
No, no,
and
it's not.
that extends beyond India in the neighboring countries of ASEAN. So it's so nice. You are a bridge between all of us. And
No, no, it is you who have brought up these things. I am just a messenger.
actually, as they say, necessity is the mother of invention. So COVID pandemic necessitated these kind of interactions, and at least in that sense, we should be grateful for this disruption that has happened. In the long run, if all the mankind escapes with least amount of damage, more good will come out of this. More good will come out of this pandemic than the bad, I guess. Let's hope so. So it's four minutes after 7, and I think we should begin without waiting for further people, because those who have missed the initial part can always check online. Okay. So uh, shall I begin, Dr. Mondal? I will begin with the introduction, and then you say few things and start sharing.
Yes, we can start.
So, good evening, all our online friends, pathologists, teachers, colleagues. Very good evening to all of you. This is Dr. Sachin Kale welcoming you to PathoIndia Webinars of the Path, by the Path, and for the Path series 2021. Happy New Year to all of you, first of all. And 2020 has been a hell of an year for all of us. Enough has been said about it. It has been an year of financial loss for some, personal loss for some, but for rest of us who are lucky enough not to have suffered any of such losses, majorly losses, I would say, it has brought certain good things to us. And I think this dark COVID cloud has definite silver lining. And we have taken some this period off period, that's slack period was there, the lockdown period was there, for learning new skills. Many of us have learned new skill, many of us have learned cooking and lot of other things. Many of us have taken our current skills in pathology or something else that we are doing to new levels. And importantly for all of us, the Indian online pathology content has come of age. I think you know all the things that are going on in the Indian digital pathology scene. There are so many leading institutes, individuals, and social influencers who are actively putting out content on the internet, and a lot of us are gaining a lot, including the people who are having more than 20 years of experience. Those people are also gaining a lot through interaction with people like Dr. Mondal and others. With this, I think it's time for us to kickstart the 2021 academic calendar. And to open the innings, we have a very able and experienced campaigner with us. His zeal for teaching and learning is nothing short of missionary. And all of us know that he spreads good vibes, much like an angel. So without much ado, let me welcome Dr. Asitava Mondal as the first speaker for PathoIndia Webinars of the Paths, by the Paths, and for the Paths 2021. Dr. Mondal, as you know, is a MD from prestigious Postgraduate Institute of Medical Education and Research, Chandigarh. He was president of Indian Academy of Cytology in the year 2006, and he worked as a vice president of IAPM in 2013. He is recipient of 19 gold medals and 10 silver medals. He has published more than 100 articles in national and international journals. He has delivered orations in various states of India and also abroad. He has been invited as guest speaker in more than 150 national and international conferences. He was felicitated with Lifetime Achievement Awards from Jharkhand, Rajasthan, Chhattisgarh chapters of Indian Association of Pathologists and Microbiologists. He is on the editorial boards of number of various journals also. So what an academic record, and still his enthusiasm is not on the wane, and it's on the increase as the days are passing. So it's a very gratuitous thing for all of us that he is enthusiastically agreeing to be the opening batsman for 2021. Today he is going to talk about diagnostic approach to mesenchymal tumors of maxillofacial region. I think with this I am ready to hand over the stage or the screen to Dr. Mondal, and as usual I request audience to inform us about any problems in the YouTube comment section, or you can ask questions in that which Dr. Mondal is going to take at the end. And all of us, please remember that there is some lag between what we are transmitting and what you are seeing. About 30-40 seconds lag is there. So please bear with us regarding that. With this, over to you, Dr. Mondal.
Thank you, Dr. Sachin Kale. It is really a proud privilege and great honor to come before the audience, and particularly before you, to highlight something in pathology in 2021. In 2020, we have done a good amount of webinars, and it is a continuation of 2020 to 2021. But I am lucky that you have given me the honor of the opening batsman of 2021. Your inspiration and your encouragement helps me a lot to make one after the one series of webinars, one after the, and it is the blessings and encouragement of my friends in our ACH group on national and international forum. Their encouragement is so high that you cannot keep quiet in spite of this pandemic COVID. You have to work and you have to give whatever you get to disperse the knowledge amongst all. So with this short introduction, Dr. Sachin Kale is very close friend of mine. Whenever he tells something or requests in such a soft tone, I cannot tell no. Whenever he tells Dr.
So
Mondal, now
kind
it
of
is
you,
your
sir. So
turn,
kind of you.
but I cannot tell no. I have to accommodate myself. In November, he told me that after the vacation in December, we'll start in January. So I opted that whether it is possible, and immediately I agreed, yes, he will be the opening batsman. So this type of encouragement a person gives in front of you and guides you is really very encouraging. I will request some of the speakers who are over here, some of the audience who are good speakers to contact you and to continue with
Yes,
the
sir. We very
webinars.
much need it.
And, for example, there are some persons from Gujarat, then from Bihar, there are persons who can highlight in your webinars and we can share
Yes,
our
sir. Yes, sir.
knowledge.
Definitely.
And
Dr. Lalani is there. Dr.
not only give us the knowledge, we bring the friendship. We know
Yes, sir.
each other. And we may not meet in true conferences, but through webinars we can make friends. We can know their knowledge. We can know how much they are working behind in the laboratories, how much diagnosis they are giving. So this is very important for us. With this short introduction, now let me start the
Yes,
lecture
sir.
on diagnostic approach of malignant mesenchymal tumors of maxillofacial region. Slides are seen.
Yes, sir. Slides are seen. Sir, your screen went away, I guess.
Is slide seen?
It was there. It just
Is
disappeared.
the slide
Please,
seen?
no, sir. No, no. Please share it again. It was seen, but then something happened and it went away. Uh, Sir, your screen was there, but it just went away.
It's
Uh,
1 minute.
it was there, but it went away.
Will I start again?
Uh, Sir, you have to share again, sir. Have you shared?
Yes, let me
Please,
start again.
please do it again. Please do it again. Yes, sir. Now it
Now
is
it has
coming.
come.
Yes, sir. Now it is coming.
Now, wish you all Happy New Year 2021. In this new year, we look after not only our academics, we need our friendship. Friendship should grow because true conferences are not happening. But through webinar, we can expand our friendship not only in our different parts of India but also from abroad. And the importance of webinar is that in true conferences, actually, we meet friends from a particular state, and some of my friends come from different parts of the country. But in webinar is a platform where we can meet friends from different parts of India, and there we can see each other, meet each other, share our knowledge. But the fragments of meeting, the fragments of staying together, meeting, having a cup of tea, gossiping, that is lacking. But at least for the time being, till the COVID is under control, let us move to webinars. So with 2021, we will have happiness, peace, satisfaction in not only in our academics but also in other parts of our family meeting, and though it is restricted, but with the wearing of masks, hand washing, and maintaining some distance, we can carry on with our safely. Wish you a healthy, very healthy, happy new year. So the diagnostic approach to mesenchymal tumors of maxillofacial region. This is the fifth teaching session on cytology. This is not for publication, but it can be learned from the YouTube. Now, maxillofacial tumors, if we classify, it is mainly of two types. One is mesenchymal and epithelial. Of the mesenchymal, we classify in the soft tissues, bone, and hematolymphoid tissues. So today I will highlight on soft tissue tumors of the mesenchymal origin involving maxillofacial region, bone and hematolymphoid tissue in the next, followed by epithelial. So there will be a series of 3 lectures on the maxillofacial tumors. So diagnosis of maxillofacial tumors. Not only it is maxillofacial tumors, any tumor of the body, any swelling of the body, where usually 3 persons are involved. And Dr. Pranab Verma from Bihar actually gives stress to his students, to his colleagues, that at least patient's photograph, the CT or imaging finding, everything should be given. Otherwise, we will not share our experience. That is a very strict criteria laid down by him. I really appreciate his tedious job of highlighting these 3 topics. That is, one is the surgeon. Surgeon or oncologist is a person where the patient comes first. He or she examines the patient and then he advises for a radiology. Means either a plain X-ray, ultrasonography, CT scan, HRC, CT, MRI, etc. to assess the nature of the lesion and where it is situated, how much it is involved, the vascularity of the lesion, tumor and necrosis, margin, etc. can be made out. And after the radiologist, we come to the cytologist, means the diagnosis. So actually we know the tumor, then the exact histology or the cytology of the tumor depends on a very competent pathologist who must be well versed with cytology or histopathology. So these 3 triads are very important for a correct diagnosis. Now, diagnostic approach of maxillofacial tumors, this clinical presentation is very important because we know that in maxillofacial tumors, from the face it goes to maxilla or maxilla to face, it is very difficult to diagnose by clinically because the clinical examinations may not show a swelling in the face, but the patient has a massive maxillary tumor. On the other hand, the patient may have a swelling on the face without involving the maxilla. So the clinical presentation, there is the fixity of the lesions, the redness, the tenderness, the size, the involvement of the skin, deeper tissue is very important. And the site of origin of tumor is also important, whether it is arising from maxilla or the surrounding tissue and then infiltrating the maxilla. And for this, image is very important, that is high resolution, contrast in and CT. Simple CT will guide you to put the needle, but if contrast we give, then we can make out the total delineation of the tumor. And that is very important. After that, we can do the cytology, means we can get out the cells from the tumor, and the cells can be studied by H&D, PAP, and others, and the special stents as it is necessary. And the part of the material can be made for cell block. And from the cell block, paraffin embedded cell block, we can do the histopathology as well as the IHC. Now, after the diagnosis is given, usually if by a competent cytologist, the surgeon then goes for an operation, either by total excision or debulking surgery, whatever is there. Then the gross tumor should be sent. Usually it is better to send to a cytologist who has done the histopathology. If the surgeon needs a second opinion, the rest of the tumor, paraffin blocks, all can be handed over to the surgeon. Because the cytologist has examined the patient, he knows about the tumor, he knows the extent, how much is involvement, and from there, grossing becomes easy. The importance of grossing is that the pathologist himself should do the grossing, and if necessary, should take the photograph before doing the gross examination. That will help us to correlate the tumor with the imaging studies. Now, treatment of maxillofacial tumors, if we see, there are 2 modes of treatment. One is surgery, Another is when surgery is not possible, we can go for neoadjuvant chemotherapy, radiotherapy. Why these are given when the surgery is not possible? To reduce the size of the tumor. When the tumor is reduced in size by neoadjuvant chemotherapy or radiotherapy, then we can go for wide local excision or debulking surgery. Where the facility of a good cytologist is not there, then the two persons that work is the surgeon and the histopathologist. Cytologist is not available. So what the surgeon do, they take a chunk of tissue and send it to the pathologist for opinion. The problem is that if we get adequate or representative material, then there is no problem. The problem starts if the surgeon takes a chunk of tissue from the superficial area or from the necrotic area of the tumor, then the problem starts. Then the pathologist cannot give a conclusive report, but the surgeon is very adamant that I have taken a proper representative tissue. But then a repeat biopsy is requested and the surgeon takes a good and he blames the pathologist that you have not given cut. But one should sit together. There should not be any misunderstanding between a surgeon and a pathologist. They should sit together, discuss that the tumor, the biopsy that has been taken is not representative. For representative biopsy to be taken in case of a deep-seated lesion, the surgeon should consult a radiologist before putting a knife and a scalpel to take out a chunk of tissue, and which can be done by frozen section, surgical biopsy, or histopathology. So this close correlation between surgeon, radiologist, and pathologist is very essential to give a conclusive diagnosis. But where a good cytologist is available, the whole burden or the whole responsibility lies on the cytologist because the patient is sent to the cytologist. But the cytologist, if he only puts the needle and draw the material, then he'll end up in problem because the tissue may not be representative, the tissue may not be adequate, so that he or she should consult the CT scan or the imaging first. Then with the guidance of a radiologist, he or she should put the needle and should examine the quick assessment of the aspirated material. The quick assessment will tell whether we have get good amount of material by the whitish flex. If there is blood mixed material or there is extensive hemorrhagic material, then we cannot get good amount of cytology and the cell block cannot be done. So to put the needle in proper place in the vital area of the tumor, the guidance of radiologist with guidance of needle in situ should be done. So these are the persons who are essential required for the diagnosis, and ultimately the treatment can be done by a chemotherapist or a radiotherapist. Now the soft tissue tumors, we'll deal today with the soft tissue tumors of the maxillofacial region. But actually these are facial tumors, some may not be maxillary tumors, but how the patient is presenting is very important. So now the question comes, is CT scan essential for FNAC of lesions involving parotid region? Majority of the surgeons will tell why we need the CT scan. The patient has a parotid swelling. You can take out the FNAC from the material. Yes, in 99% or even more, we can get adequate tissue from the region of the parotid and can tell the nature of the parotid tumor, starting from chronic cell adenitis to granulomatous lesion, inflammatory lesions, and various types of benign and malignant, starting from pleomorphic adenoma, mucoepidermoid, acinic, and other types of tumors like that, what is present over there. Adenoid cystic carcinoma. There is no problem, but problem starts when we get different type of material which are not commonly seen in a parotid gland or not at all seen in a parotid gland. In these cases, CT scan is very important. It definitely, yes, in some cases to avoid false negative result. These I will highlight in which cases CT scan was essential to diagnose these lesions. The clinicians may insist that the tumor is involving the parotid gland, but do not be surprised if CT scan shows differently and avoid false negative FNAC result. One thing Dr. Sachin Kale, I want to tell you that we have slide discussion forum in 2020 for 4 continuous months. And many have joined, not only from our India, but also from abroad in the slide discussion forum. And this slide discussion forum is also being carried out previously in IPM Bihar chapter by Dr. Gono Bharma, and he used to give awards to first, second. But nowadays, with the advent of this pandemic or some or other, This has now stopped, but we should start again in 2021 the slide diagnostic seminars in our WhatsApp group. So now this is a patient where we find that the patient has a facial palsy. We can see that this part is the normal part because eye is closing, mouth is being pushed. But this is the part of facial palsy. Eye is not closing and the face is there, and along with a huge tumor. The tumor is going from the temporal up to this part and the ear is pushed out. The patient has not any pain. That is why the tumor has grown. And it has grown to such an extent that the ear is pushed out. And on FNC we found unusual type of cells which are not commonly seen in the parotid gland. Is it a parotid tumor with facial palsy? Let us see. These are the cells that we got. What are these cells? Cells are in discrete pattern. The cells have scanty amount of cytoplasm. Some cells have binucleated. Then some cells have intracytoplasmic vacuoles. And these are the cells that we found out over here, vacuoles. And if we see in another area, yes, these are the cells. These are the cells that we got it over there. So basically round cell tumor in the parotid region of a child aged about 3 years. So this is 3 years child. And this is the lesion over here. This is the lesion. So this is ear. So this tumor has grown from the ear involving the mastoid region with destruction of bone. And this is the soft tissue tumor. It is not a parotid gland tumor. See, we can see this is the extension going from here to here. So big is the tumor. And from CT, we can also see this is the tumor going from here to here. So that is the importance of CT. It tells us that it is not a parotid gland tumor, but a soft tissue tumor with bone destruction. So what is this cells then? Then we did a biopsy, and biopsy shows similar type of cells that we got on cytology.
There are some comments coming up. There are some comments coming up in the section. Shall I read them out?
Yes.
Dr. Sharma is saying lymphoma. Dr. Nabanita is saying Burkitt's. And Dr. Junu Devi is saying Burkitt's lymphoma. So these three the others might have commented already, but it will take some time for comments to appear.
Acha, let us see what is there. It is basically a round cell tumor in children. I am very happy that they are giving comments. That is the way we should proceed.
Yes, sir.
We should not have ego. It is a platform where everyone can share their feelings, and everyone is welcome to give their feelings. That is very important.
Dr. Pranav Verma is saying malignant round cell tumor.
Yes, that is a broad classification. Malignant round cell tumor in a child of 3 years of age involving the facial region. The cells we can see there are plenty of mitotic figures.
Dr. Lalani is saying alveolar rhabdomyosarcoma.
Yes, that.
Rhabdomyoblast.
Dr. Lalani is very experienced, but everyone has given their view. That is most welcome. Whatever is there, but they have given their views. Yes, that is a friendly affair. The friendly attitude means all are feeling on the same platform. Whatever they are feeling, they are telling, and we will take up. So basically, it's a round cell tumor, isn't it? And the cells have scanty to moderate cytoplasm. The cells, most welcome, Junu Madam from Assam. And I know that you are very much academic minded, and you have promised that you have joined. I'm very happy that you have joined over here. Stay till the end. You will enjoy. So these are the cells we can see. The mitotic figures are there. The cells have scanty cytoplasm, mostly rounded tumor, round cell tumors. Now we have done thinking that some has thought of lymphoma, so LCA is negative. We have think epithelial is negative. Then round cell tumor of Ewing's group is negative. Chromogranin is negative, but muscle markers are positive like vimentin, desmin, muscle actin myosin. The child of 3 years, any soft tissue tumors, irrespective of the site of a child, of a round cell morphology, monomorphic, we should think of basically a rhabdomyosarcoma. In rhabdomyosarcomas, intracellular vacuoles are sometimes seen. In cases of embryonal rhabdomyosarcoma, if we go through the literature, we can see that the intracellular vacuoles are seen in case of embryonal rhabdomyosarcomas. So this is the cells that we got it. biopsy, this is muscle actin is positive, desmin is positive, and myogenin is positive. Now, according to the stain of ISC of myogenin, we can distinguish sometimes between embryonal and alveolar rhabdomyosarcoma according to the intensity of the staining of myogenin. So it is an embryonal rhabdomyosarcoma.
So Dr. Lalani sir
Another
got it
case.
right.
Yes, it does not matter. So who is giving right or wrong? So Dr. Lalani is very senior pathologist and one of the very senior reputed pathologists of whole of Gujarat.
Yes,
So,
Dr. Niraj
so
Simani
he,
also, embryonal
yes,
rhabdom.
yes, that is true. But we are sharing each other's feeling. We should share because after seeing the sick vacuoles inside, then the Burkitt's tumor was highlighted because of Burkitt's tumor. But these vacuoles were not. There is no histiocytes in the background. That starry sky appear. There the histiocytes. That is the engulfed histiocytes should be there along with that. And the Burkitt cell is of deep blue cytoplasm, large nucleus, and this is very important for Burkitt's, along with tingible body macrophages should be there, which was absent. Now, this is another patient we can see. Here is also facial palsy. So this is the part of the facial palsy over here, and this is part is normal. So again, where is the tumor? Where is the tumor? Is it a parotid tumor with facial palsy? Now, when the patient came to me, then the surgeon told that do FNAC from the parotid. I did not find any parotid, but the patient, see, the patient in an OPD, they do not give much attention, means they do not have time to see so much. When I asked the patient, where is your problem? There is no facial swelling. Then the patient told that he has a bleeding in the ear. And the surgeon, the oncologist, the surgeon in the surgery department, they do not give much importance for, they thought of chronic otitis media or something else and referred to ENT. And the patient was referred for FNAC in the parotid region thinking facial palsy. I was lucky to find that there is the tumor over there. This is bleeding tumor. The ear, external ear, it is totally plugged by the tumor. And the clinical photograph was taken. That is the importance of a cytologist who can take the clinical photograph. And then we did a CT scan because I was not very sure whether it is something of a purulent pus or something. Then I told the patient, do CT scan, not whole CT scan, at least take sections from this area. Limited CT scan, if we do for diagnostic purpose, the cost is very, very less. So 1 or 2, 3 cuts will tell you that whether it's a tumor or this. So actually, these 3, 4 cuts were taken because I have a very good friend on radiologist who helps me taking minimum charges and can do CT scan, means not CT scan, CT cuts of the tumor. And here we find this is the ear. This is normal ear. This is filled with air, as we found in normal ear. But this ear, there is a huge mass. The base of skull is also destroyed. Mastoid is destroyed. And this is the soft tissue tumor with bone erosion. Now, what we did an FNAC from this, and we did the squash cytology from their part, and this is FNAC was done, and this FNAC showed highly pleomorphic cells. See, these are highly pleomorphic. The multinucleated giant cells were there, prominent nucleolus was there, then there is mitotic figures were scattered. Then we were very much perplexed. What is this tumor? Is it a pleomorphic sarcoma or anything else? We could not make out because, truly speaking, we gave a possibility of a sarcoma. And see, the another area we find mitotic figures, highly pleomorphic cells. Tumor giant cells were there, prominent nucleolus was there, mitotic figures were there. But we were very much afraid of giving a diagnosis, but he's a child. So we have to think what type of tumor is there that is involving the ear and destroying the mastoid. So biopsy was done. And the biopsy was done by the ENT surgeon where we found out same type of cells that we found in cytology. We found, see, these are the multinucleated giant cells were there, mitotic figures were there, scattered rounded cells were there as we seen in cytology. Then we do desmin. Because usually we can do lots of ISC, but first we should exclude whether dealing with rhabdomyosarcoma, because there are various types of pattern of rhabdomyosarcomas. If we clinch the diagnosis of desmin and myogenin, and then even if we do vimentin, and then followed by desmin or myogeny, which as usually rules out the abdominal sarcoma. Then you can think of other possibilities. Desmin has come strongly positive. Only one IC stain we have done desmin positive. So it is an embryonal abdominal sarcoma. But after giving the diagnosis of embryonal abdominal sarcoma, we are not very much satisfied because the morphology does not fit into embryonal abdominal sarcoma. They are not rounded cells, they are highly pleomorphic, tumor giant cells all over there. But when we go to WHO classification of the recent classification of embryonal abdominal sarcomas, we have seen that the varieties of embryonal abdominal sarcoma. This is the very classical type that we have shown. This is a compact, solid pattern as it looks like as if it is a synovial sarcoma, lymphomas or other groups because the cells are totally compact pattern. This is a spindle cell morphology where we can give mistake of a spindle cell sarcoma like synovial sarcoma, then fibrosarcoma or this type of pattern or leiomal sarcomas, whatever may be, basically spindle cell type. And this is an anaplastic type. So these four patterns can be seen in childhood. And this anaplastic type was the last case. So this case, if we could see, we should not be perplexed. That is the importance of clinical cytology. Age is important, tumor is important, and then followed by remember these four morphological patterns of abdominal sarcomas. Embryonal. And if we can get this one, we must first rule out by doing desmin and myogeny. This is another child. We can see that there is a swelling over here. And this is the facial swelling. This eye is also facial palsy. Then we can see the tumor. If we see the patient, the tumor is coming in the oral cavity. There is bleeding in the nose, swelling in the temporal region, and this eye there is also a swelling. You compare this part, this is swelling. So this is very important for clinical examination of the patient. The patient has a bleeding nose. The patient has a facial swelling. The tumor is coming from the oral cavity. Then where is the location? If we see the location, yes, the orbit is involved. This is the orbit. This is the medial wall is destroyed. Tumor is infiltrating the orbit. This orbit is intact. It has gone to the brain. Then the maxilla is involved. This is normal maxilla. This maxilla is involved. Total destruction of maxilla. This is from the anterior part. And the posterior part, if we see the CT scan, it has involved the base of skull, brain, and the whole maxilla. Not only this, the mandible is also destroyed. This is normal mandible. And see this erosion over there in the mandible. So there is a large tumor in the oral cavity which is going to the maxilla, to the orbit, and to the brain. And the patient is almost showing nothing in the outside, only a part of facial palsy. So see, this is how it present. It's a maxillary swelling involving so many areas with no intact of the face. So this is, and when the cytology was done, it came very nicely. We can see the connective tissue strands, again rounded cells. But the connective tissue strands is very well dispersed. And the cells, some are attached to this connective tissue, some are floating freely in the cells, in the connective. So that gives us a diagnosis whether we are dealing with an alveolar pattern or not. Because this is basically a round cell tumor, but the cell pattern is looking whether it's an alveolar type. Yes, you can see the high power. This is connective tissue and these are the cells. So if we get a good amount of aspirated material, there is no dearth of material. Because we have to very cautiously put the needle and get this material out by under CT guidance, and the exact location of the needle is very important. So this is that we got cell, this is the high power, and this is the cell block. See, in cell block we can find the same type of connective tissue which is there in cytology, also in the histology. And the cells are also there, some attached, some floating, good amount of cytoplasm, and again desmin positive. So child tumor, do muscle markers first, followed by others. And if we do the biopsy, you can find typical picket fence pattern. Connective tissue strands, cells attached to the connective tissue floating over there, mitotic figures are here scattered. So there is now not much problem, and this is required because we have to confirm our diagnosis. Myogeny was positive and desmin positive, and this is alveolar abdominal sarcoma. Another child where we find, see, this is a very beautiful child, came with smiling, and the surgeon told this is the facial swelling to an FNAC from this area. But on clinically, I am not very fast on FNAC. I usually take a good amount of time to see the patient because See, if a routine case of cervical lymph node comes with a fluctuant mass, then it is a tuberculosis suppurative, whether it's tender or not. But this type of soft tissue tumors, we must give some respect the patient, respect the tumor. So apart from the parotid region, we can find that the temporal is swelling. See, this is the part which has swelled up, this part. And this part is very tender. This part is very tender. So now the tumor is coming from here, going up to there. So this is not a parotid tumor. I told the surgeon, sir, it doesn't look like a parotid tumor. Why there is a swelling in the temporal region? No, you do the FNAC from the parotid as advised. So that is the problem that we face. We have not the freedom of doing something. It is only in the hands of a surgeon. But as he has told, I put a needle, but what we get is totally a false report. See, this is normal salivary gland tissue has come up. Nothing, no tumor. Only normal salivary gland epithelial cells have come. So I have told that I will not dispatch the report because the patient will end up in problem. I may refund the money, but the patient should come with a CT scan and I will perform a repeat FNAC free of cost. I will not take cost, but it's my responsibility to give a diagnosis. And then the surgeon told that yes, as he has advised, do CT. Is CT scan essential for a parotid region? Definitely yes. So this is the patient, 12 years male child, has a mass in that lateral pterygoid muscle. You can see this is normal here. Here the bone is also destroyed. See, this is the normal bone. This total bone is destroyed over here. This bone is not here. This is the tumor which is bulged outside. And this is the temporal region swelling, where there is a pain and tenderness. So it is a tumor arising from the pterygoid muscle in the base of skull, and this CT guided FNAC has been done, and on CT guided FNAC we found these type of cells. What are these? This is a typical multinucleated giant cells of a wreath-like pattern. Wreath-like pattern of multinucleated giant cells in a round cell tumor in a child with plenty of mitotic figures. So basically also a round cell tumor, but the accompanying cell is a tumor giant cells having a characteristics nuclear pattern. This is the pattern. So if we see this is the pattern and on cell block, same pattern was there. So once we get the tumor and once we see that's a solid fleshy tumor, no necrosis, we can put the needle and get adequate material and do the cell block. And see, this is the cell block can be made out because typical characteristics of a cell block pattern is there. So rounded cells, then the giant cells of wreath-like nuclei as we found on the cytology, and this is the high power. If we found a round cell tumor in a child having a mitotic figures and this type of nuclear, we should think of to a panel which are positive for muscle lectin and myogen. This much is sufficient, or desmin and myogen. These are not necessary because we cannot think of lymphoma, we cannot think of PNET or round cell, we cannot think of other tumors. So it is basically a round cell tumor, and this myogen it was very strong. Same type of cells that we found with over here, multinucleated giant cells were there. On cytology that we found also on the histology and IC, same type of multinucleated giant cell wreath like this. One side there is a tumor giant cell, this part is free. So this one type, this is called wreath-like nuclei, and this is a solid variant of alveolar rhabdomyosarcoma. So these are the rhabdomyosarcomas variants may found in a child. And what is the importance is that treatment of embryonal and alveolar rhabdomyosarcoma is totally different. Prognosis alveolar rhabdomyosarcoma has a poor prognosis in compared to embryonal. And an alveolar rhabdomyosarcoma, the blessings is that we cannot distinguish so much by cytology. We cannot distinguish even by IC. Myogen in staining differentiation is there, but more on theoretical. In these cases, FISH is very important. And for that, we can see we have to do the fusion of FOXO1 gene with PAX3 or FOXO1 gene with PAX7. So this is the part which is very important for diagnosis of alveolar rhabdomyosarcoma. The fusion of FOXO1 gene with PAX3, which is most common, has a poor prognosis compared to of FOXO1 gene and PAX7. So these 60% cases are positive for PAX3 and FOXO1 fusion gene. See, this is another patient. See, there are multiple patients with facial palsy, and these are not at all parotid tumor. So this is another case of facial palsy. You can see this part is normal, this is the tumor. But if the tumor is absolutely in the facial region, in the parotid region, this is the classical area of the parotid. So is it really a parotid tumor? Is it a parotid tumor with facial palsy? This is the FNAC. What we found in FNAC, two types of cells. What are these? These are rounded cells and these are spindle cells, right? These are spindle cells, these are rounded cells. What are these cells? These are parotid gland tumor epithelial cells. What are these spindle cells? Let us see what are these spindle cells are. Yes, these are spindle cell palisading pattern. This is compact area, these are loose areas. This is a spindle cell pattern. So now we are thinking whether it's a tumor of the facial nerve, means whether it is a schwannoma. Because this is patient has facial palsy, there is a parotid, and in the parotid between the superficial and the deep lobe, the facial nerve goes. So the facial nerve is involved, giving rise to the facial palsy. And now we have to do a CT scan, and CT scan shows yes, this is a tumor of the parotid region. We can see this is normal parotid gland, and this is the whole tumor, the parotid of a 60 years female. So this is the tumor. So the diagnosis we have possibly we thought of a spindle cell tumor in the parotid region, possibly coming from the facial nerve, which has given rise to facial palsy. And the tumor is removed. See the beautiful tumor of the parotid region. This is normal parotid gland. This is the facial nerve, and this is the tumor. The tumor itself, when we slice it, we can give a diagnosis of the soft, homogeneous, and very mixed. When the scalpel goes through the tumor, we can make out that it is something to do with a neural tumor. So on histology, we can find two types of pattern. There's Antony B pattern and Antony A pattern compact, very classical area of this of a schwannoma, isn't it? It's a very compact spindle cell pattern. There is some nuclear pleomorphism, but not much of mitotic figure. See the very palisading arrangement of the cells. And this is the loose myxoid area, this Antony B and Antony A pattern. And this is the high power of the Antony A pattern, where we find the cells are compact. So we have diagnosed a case, but only for confirmation we can do an S100 step. So this is Antony B pattern, this is the Antony A pattern, and this is the compact pattern. S100 is strongly positive. So schwannoma of the facial. So this is the way how we come to the conclusion of it. How step by step we come to conclusion from cytology, imaging, then cell block, histopathology, and then IHC. This is another tip.
So,
The
sir,
patient
please, there are a couple of comments for this case. Dr. Junu
yes,
Deke identified schwannoma just from the gross itself, gross and the initial images
yes,
of
yes,
cytology.
yes, yes.
And
Very good to know, madam. Very good because once the pathologists do grossing, nah, he or she can make it out because fix if we do the photograph of a fixed tissue we cannot make out, but if we do a fresh tissue, and she has shown
good point.
plenty of cases on gross examination when she was doing the slide seminar from Assam, then we have enjoyed her cases very much because lots of gross specimens she has shown us.
Great,
Excellent
great.
cases from the ovarian tumor, then female genital tract tumor, then coming adrenal tumor, all varieties she has shown. And
Okay,
her TD, her work is very much appreciated by all our group.
great, sir. Dr.
So,
Pradeep Sharma has said great case.
and Manoj Kahar is also another. He is from Gujarat,
Yes,
but
sir.
he is very, 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 very sincere. Pranab from Bihar. These are our assets of
Yes,
our
sir.
group. They are our assets of our group and from different parts of India. And we are really blessed to have them in our group.
Yes, sir.
And we are enjoying every day almost cases like that. And Junu madam sometimes she send cases for discussion or this. We do not have any ego or we do not have superiority inferiority complex. Whatever we feel like we discuss, and it becomes beneficial to all. So this is another patient of an
There is
elderly,
some
and this is a
comment saying
facial.
network problem. And if you are able to hear properly, so just comment that we can hear it properly. So it must be at your end.
So now this is the tumor, and there is no facial palsy. The ear has been pulled out. This is the tumor, large tumor. And on CT scan, we can find a huge tumor over here. Whole mass is there. And this is the ear, multinodular swelling. You see, this is the multinodular swelling. On the CT, we can make out solid fleshy mass without much hemorrhage or necrosis. And see, this is the tumor. We can make out a solid fleshy tumor and highly pleomorphic cells, round cells, then spindle cells, tumor giant cells, myxoid material in the background, and very good yield of the cells. And again, we can see here we did a cell block. The cell block was lucky that we can get a typical pattern. What is this pattern? Storiform pattern or cartwheel pattern. Pleomorphic tumor giants, pleomorphic malignant cells, multinucleated, binucleated, and this pattern is very important on the cell block. And after that, this we did a cytokeratin was negative, hymentin was positive. So basically, it's a mesenchymal tumor. But the pattern of this of the story form possibly give rise to a diagnosis of malignant fibrous histiocytoma or high-grade sarcoma, possibly malignant fibrous histiocytoma. And histopathology was very classical. The histopathology also a storiform pattern. The histopathology is definitely looks like the malignant fibrosis tumor giant cells where they are multiple. But this type of tumor to diagnose properly, we have to do a good number of IC. That is very important. So we did an IC. Base mean muscle marker is negative. HMB45 is negative, is not melanoma. CD34 was positive only in the vessel wall, but not the tumor. Tumor is negative. We can see the tumor negative only on the vessel wall. Then SMA is focal positive. S100 is focal positive, means there is certain amount of differentiation, but not full differentiation. Basically, an undifferentiated tumor, focal positivity of SMA, S100, CD68 was positive in the giant cells, and proliferative index was 40%. So based on that, and this was an outsource. The IC was done from outsourcing, and from Bombay it was done, and they gave a diagnosis of possibly malignant fibrous histiocytoma. And we have not done the IC in this case, and because of the so many IC pattern was variable in this case, and ultimately we gave a diagnosis of pleomorphic sarcoma, undifferentiated malignant fibrous histiocytoma. But on cell block, we had the idea of the pattern of storiform that possibly of MFH is there. So this is another patient. The clinical examination give a diagnosis. Anyone from the clinically can give a diagnosis. Multinodular tumor, multilobulated tumor. I will give a clue. And these are the prominent veins radiating out. Prominent vein.
So
Patient does
audience,
not
do
have.
you want to have a go at the gross picture that is being shown, the clinical picture that is being shown? Dr.
Which one?
Asitava is expecting some answers from this, I
And
guess.
because I will give a clue. This is a multinodular swelling, elderly male, prominent veins radiating out, and these are the areas when I, before putting the needle, when I pressed it, it's a compressible tumor. The tumor was compressible. I put it on the thumb, the tumor is going down. Then when I released the thumb, it was coming out just like bubble. Slowly it was coming out to the posture. The veins were there, very prominent. You can see the veins is radiating from here, going there, prominent veins in the tumor and multinodular. Any idea of? And this must be,
Vascular tumor is one comment. Vascular tumor.
yes, absolutely correct. Vascular tumor. Why we should have a clinical examination? If we see a vascular tumor, we must be very cautious to put the needle. Why? Because if we put the needle in these areas, we can get blood only. But if we see these nodular areas where this tumor is growing, these nodular areas, preferably these nodular areas, where there is no vascularity. See, these are the areas highly vascular. If you put the needle, you will get blood. But this is the area where there is no vascularity, no blood vessel. These are the areas no blood vessel. So we have to put the needle in this fleshy part. And don't, after putting the needle, we should not give a huge suction. Slow suction should be given so that we can see the material, what is coming through the nozzle. If we get a little amount of material, sufficient to give a diagnosis. So this is the importance of clinical exam. Majority of all will put the needle over here because it's the most bulgy, easier part. Put the needle and only blood will come out. But if we take a little bit tedious way of putting the needle over here or here or here, then we can get good amount of material. And the patient had a huge mass. You can see the whole maxilla. This is the one part, and one maxilla is destroyed, orbit is destroyed, and brain is involved. It's almost inoperable case. We could not advise this patient for biopsy because cytologically we have to give a diagnosis in this case. Otherwise, the patient will have lots of problems. So this is the responsibility of a cytologist. And on FNAC, we can get good material. Yes, these are the blood vessels. Endothelial cell proliferation as we expected. and tremendous amount of endothelial cell proliferation with pleomorphism. And there were plenty of RBC in the background also. So, and this is the cell, we can get good material. And this is the microbiopsy. So when I was going through the IAPM literature about 7 or 8 years ago, one paper was there on microbiopsy. What is microbiopsy from cytology? In cytology, particularly in tumors where there is necrosis or hemorrhage, then we must decant, we must dust the slide, just turn it slowly, let the blood come out from the slide. Then we can see the white fleshy part. And this fleshy part is almost similar to an endoscopic biopsy. The small tissue fragments are there. And if we process these small tissue fragments, that is called microbiopsy. And this is the term used by the pathologist, and this is an original paper on microbiopsy, but the majority of the pathologists are not fascinated by cytology, so it was not followed up. The paper was published, but it was not followed up by other pathologists because not much is interest, because one has to develop a passion in cytology. So this is microbiopsy was done. Majority is blood, there is no doubt about it. But these are areas of surviving endothelial cell proliferation, which gave us a clue that it is possibly CD31. So only from cytology, microbiopsy, and cell block, not cell block, microbiopsy, we did not do cell block. The small tissue fragments that were present there, we just took out by the needle and put it in formalin, and then we do the cell block study, but not spinning. And this is microbiopsy and this CD31. So it is whoever has told the diagnosis of vascular tumor is very well diagnosed from the clinical examination. So this is angiosarcoma of facial bones with infiltration to brain.
Yeah, so number of people got it right. Dr.
Yes,
Neela
yes.
Srimani, then Junu Devi ma'am, and Sandeep Kumar Singh, Pradeep Sharma. A lot of
Yes,
people
very
have
good.
commented as Dr. Neelam Srimani. All have commented as angiosarcoma.
Very good, very good. That is the pleasure of webinar. See,
Yes, sir.
if we expose ourselves that properly the things, then one diagnosis would become out.
Yes, sir.
Yes, it's a very good. Thank you very much. So this is a child, not a very young female, and this is a maxillary swelling over here. So this is the tumor. We can see that a huge maxillary tumor, destruction of the bone, soft tissue was there, bulging out, and this is the tumor over here. And we can see these are the spindle cells, pleomorphic. Some are typical spindle cell. There are some large cells. There are some pleomorphic cells, some rounded cells. Then we did a cell block, but in cytology we did not find these cells. What are these cells? In cell block we found it. These are the cells. Along with the spindle cells we have got it, but with these cells we did not find in cytology. What are these cells? What are these
Any
cells?
comment, audience?
These are not round cells, dark stained nucleus and very small, but they are present in clusters along with the spindle cells. Good amount of these cells are there. We cannot ignore them. Our eyes usually goes to these cells. There, spindle cells are there, no doubt. But what are these accompanying cells?
People must be commenting, sir. Mast cell is one comment by Dr. Nabanita. Mast cell.
One variety is yes, it can be, but the characteristic of mast cell that pinkish granular cytoplasm was not there. It is almost filled with the nucleus.
Any other
And
guess?
now we should stick it to the diagnosis because these are inflammatory cells, lymphocytes. Lymphocytes are there. And that is the difference between seeing under microscope and slides. Because if we see under microscope, we can make out these cells. We can make out these cells. Yes, these cells are lymphocytes. So lymphocytes mixed with the spindle cells. So one diagnosis that come in mind is whether it's an inflammatory myofibroblastic tumor. And yes, we have done this. Vimentin was positive, cytokeratin was negative, EMA negative, S100 negative. It is not a schwannoma group, not a muscle tumor, not an epithelial tumor, not a synovial tumor, but of a Vimentin. SMA was positive, ALK1 was positive. That gave a diagnosis of inflammatory myofibroblastic tumor. So this Vimentin is positive, ALK1 is positive, and SMA was positive, and this is the cell block. So we took out the tumor. That morphology of the tumor was very disgusting. That means a horrible tumor. Though it was looking like a borderline malignancy, but when you did the histopathology, the same type of inflammatory cells, lymphocytes were there. But see the spindle cells. The spindle cells have become totally pleomorphic. So this is a highly aggressive because we can make out from this CT scan itself gave an idea. The CT scan showed that it's an aggressive tumor because total bone destruction, maxillary outer wall destroyed. Then this maxilla is involved, the nasal area is involved, this maxilla is normal. So this gives an idea that though it is looking like not a such a disgusting or such a highly malignant tumor, but on cytology it was giving an idea that possibly we are dealing with a malignant tumor because of this. But cell block was there, and we are more biased with these cells and the lymphocytes, possibly of inflammatory myofibroblastic tumor. But on histology, again come to the conclusion that it is a malignant variant of inflammatory because of aggressive nature. The lymphocytes were there, but see these cells, these cells. So this is an inflammatory myofibroblastic tumor, but only inflammatory myofibroblastic tumor will not do. We must give the surgeon that it is basically a malignant tumor which is infiltrating the bone and the soft tissue, and total maxillectomy and total radical surgery should be done because this patient do not respond to radiotherapy or chemotherapy. Now
Yes,
this
sir.
is a
There were few comments. Pradeep Sharma, Dr. Junu Devi, Dr. Shamim Akhtar, Dr. Neelam, all got it right, sir. Just
oh
two.
good, very good, very
Yes,
good, very good.
yes, sir.
Congratulations. Congratulations, madam. You have done great. And you are that shows that how much rapt attention you are seeing the cases. And that is a great pleasure. And I promise you that every month I will try. The next I will do the bone and hematolymphoid, then
Great, sir.
epithelial.
That
It
would
will
be
go till
great.
March. Till March.
Yes, sir.
So this is a and with Sachin Kale's encouragement, I cannot tell no.
Yes, sir. Thank you.
He encourages very much, and this is a elderly female, and this is another maxillary tumor. See, this is the tumor. This is the tumor, and see the maxilla is totally destroyed. This wall is destroyed. It is coming out from here. This is coming from there. Orbit is involved. Base of skull is involved. Huge tumor, and these are the cells. What are these cells? Two populations of cells, spindle cells, and these are the clumps of possibly epithelial cells. Spindle cells and epithelial cells, soft tissue tumor. So now I think majority will give a diagnosis of spindle cells and epithelial cells in nature.
It will take some time, sir. Comments will come.
Yes, yes.
It will take some
No problem. No problem. Again, I will show. This is the patient, large tumor.
Yes, sir.
This is the CT scan showing the bone destruction and involvement. And this is the cytology. Two populations, spindle cells and epithelial cells.
Synovial sarcoma is the first comment by Junu Devi, ma'am.
Junu Devi is excellent. I told you. She is very good. She is very good and very competent pathologist and cytologist. But only thing we are missing in our conference, true conference, she is not coming.
Yeah.
She should come in 2021. This is my personal invitation to her.
Yes, sir.
And it is a very good diagnosis.
Dr. Navalita
So
is also
now,
saying synovial sarcoma. Dr. Shamim.
yes, absolutely correct. Absolutely correct. This is the C. These are the epithelial cells. This is the epithelium, and these are the spindle cells. Very good diagnosis. Yes, these are the cells filled with mucin, glandular epithelial, spindle cells. There is no problem now with the diagnosis.
Sir, one more
And
thing
see,
from
this
my
is
side. Just in that particular region, there is one ameloblastoma is also one possibility, but could it be so destructive and
amyloblastoma.
bifacial?
But see that amyloblastoma will not go to such an extent.
Yes, sir, that's true.
It will be restricted to these areas.
Right.
But maxilla, then orbit, then base of skull, this much will not go. Amyloblastoma will be up to these areas. This area will be amyloblastoma, but not these areas.
Yes.
One possibility is there because that is the importance of CT. CT tells that it is not. CT, if the tumor is this part, suppose this area, we can think of it definitely. But when this is involved, Usually it does not go to amyloblastoma, but the cell pattern is definitely is there. But and this is the tumor, and these are the glands epithelial, mucin is there, spindle cells are there, and this is EMA is positive, hymentin is positive, BCL2 spindle cells. Then based on this, we give a diagnosis of biphasic. TLE1 is coming up. TLE1, they are telling that it is a very characteristics of synovial sarcoma. But TLE1 nowadays, we can see it is positive also in other tumors like neural tumors. So if we have a suspicion, then we can, even CD99 becomes positive, EMA positive in cases of synovial sarcoma, EMA positive. CD34, if it is always negative in synovial sarcoma, it is inflammatory. And this is negative in synovial sarcoma, BCL2, hymentin, EMA, TLE1, CD99. These are usually positive in case of synovial sarcoma. So biphasic synovial. But problem starts when we have does not take up the stain, or in case of poorly differentiated, or we can know that it's a biphasic, monophasic, and undifferentiated. These are three types. But biphasic is very characteristic. Monophasic creates problem. Biphasic sometimes create problem with sarcomatoid carcinoma, and monophasic usually sometimes create problem with other spindle cell tumors. Undifferentiated round cell tumors create problem with Ewing's. So in these cases, when there is overlap of IC, then we have to do the molecular studies, that is SYT SXX1 fusion or SYT SXX2 fusion. That is very important for biphasic or monophasic synovial. And then we have to move to FISH, because synovial sarcoma is totally an undifferentiated. The cell of origin is not known. It's a very aggressive tumor, known for recurrence, metastasis, and all. So when confusion starts with IHC of a spindle cell or monophasic or round cell or sarcomatoid carcinoma biphasic pattern, then also in monophasic with the Ewing's tumor, then we have to do for the FISH technology. Now this is a patient. Can anyone highlight what is there in the patient? This is the tumor we can see. This is not a squamous cell carcinoma because of nodular nature. This is not ulcerated area, which is usually squamous cell area, got fungated, ulcerated, mucosa destroyed. But here we find that it's a projecting nodular lesion. And this is the area of this. This is the tumor. But what is there in the apart from this? If we see the patient clinically, what we can see? I have given the arrowheads. The patient has been repeatedly, surgical intervention has been done earlier. So this is the mark. Why surgical intervention
Cleft
was
palate
done?
is one. Somebody. Nabanita is saying cleft palate. Nasal bleeding.
Now, why cleft palate? It's not cleft palate. You can see nasal bleeding is there. Yes. Nasal bleeding is there. See, compared to this nostril is also enlarged. There is possibly a mass coming from outside. Palate mass has gone there. So incisional mark is there. There is definitely incisional mark from here, coming from there, coming from there, coming from there. So is it a failure of surgery? The tumor was not taken out. Is it a recurrence or something? We have to see, but we cannot. We have seen that something surgical intervention has been done in this case. So this is the tumor. We have seen it. How much is the big is the tumor? Now, if you see the orbit is involved. So this is the orbit, and this part orbit is there. Whole maxilla is there. Palate is destroyed. This is the palate. See, total destruction of the palate, and coming from the palate, it is coming in the oral cavity. We have seen the tumor in the oral cavity. Yes, this is the tumor. And we can see the CT. Yes, this is the tumor. This is the palate is destroyed. So this is a big tumor. Possibly the surgery could not be done in this case. And on FNS, you can find a spindle cell pattern. Palisading patterns, classical spindle cells. But clinically, we had a doubt. Why this multinodular? Multinodular pattern. It is not a rounded solid tumor, multinodular pattern. And these are the spindle cells. The spindle cells gave an idea, possibly a neural tumor or something else, because of palisading spindle cells, mild to moderate pleomorphism, some mitotic figures are there. But on further cytology, we can find the tumor giant cell has become highly pleomorphic. So this is the importance of doing FNAC from various sites. If we do one site, we can get this type of cells. But if as we puncture one or two areas, we can get a variegated appearance. See, these are the cells that we saw. Tumor giant cells were there. The spindle cells have become pleomorphic, and see, these are binucleated. This is the spindle cell, basically a spindle cell tumor. And when cell block, beautiful cell block has come out, we can see that this is definitely malignant. We can make out from the CT itself it is malignant. Morphologically spindle cell, possibly neural, and cell block also supports it. See the spindle cell, see the pleomorphism, see the mitotic figures, plenty of mitotic figures, and tumor giant cell. These are the another mitotic figure. If we see it's plenty of mitotic, see these are the mitotic figures. We can see the nuclear pleomorphism, spindle cell. Yes, diagnosis is almost clear in this case.
MPNST. Dr. Januddin
Yes,
is
yes.
saying MPNST.
Yeah, absolutely correct, madam. You are absolutely correct. There's no
Dr.
doubt. It's 100.
Meezashimani also.
Yes, it's correct. That is why slowly we should progress and one should enjoy. And now this is S100 is positive. So this is a tumor was taken out. See huge tumor. This is the palatal part. This is the maxillary tumor. These are the multinodular areas that we have seen in the palate. See this, we can see the tumor multinodular pattern. And if we see, this is a very pattern that we have seen in cytology. Palisading pattern is there. The cell's nuclear pleomorphism is there. Mitotic figures, and we can see there's plenty of mitotic figures scattered. So these are the tumor and multinucleated giant cells, mitotic figures are there. So it was not much problem. We get to a malignant peripheral nerve sheath tumor.
Intranuclear inclusions are seen. That was the comment by Dr. Verma. Intranuclear inclusion. Would you like to say something about that?
There
Intranuclear.
were some, there was some inclusion, but it is also seen in MPNST.
Yes, yes.
It is also seen in MPNST.
Recurrent growth. It's a recurrent
Yes,
growth.
yes, it's a recurrent growth. Absolutely correct. A recurrent growth.
Dr.
Possibly the tumor was removed initially a part, then again recurred because incisional mark is there. Now this tumor created problem. The patient is an elderly. This is a swelling in the facial region. What we see apart from that, we can see this part of face is swell up, right? I have covered the eyes, but if you sort not covered, we can see that reddish tinge, absolutely angry looking eye, and supraorbital ridge is completely filled. So compared to this side, this is a groove, this is the normal. But see this part is filled with the tumor. So tumor is here, it is possibly here, and it is possibly there. And if we just palpate and give pressure, these areas will show tenderness. So this is the area of involvement. Now on CT scan, we can find absolutely the same. The orbit is totally destroyed, the eyeball is destroyed, then maxilla is involved, and part of nasal cavity is involved, invading up to the base of skull. So this is a large tumor, but on outside, if we see the clinically the patient, and we can see here, it does not look such a ghastly tumor, but it is possibly a tumor in the nasolacrimal gland area. Right, this is the tumor. Possibly the ophthalmologist will diagnose possibly a nasolacrimal gland tumor involving the skin, but on CT scan it is not. It is the orbit, nasal cavity, maxilla up to base of skull. Now cytology gives a clue. What is this? It's a myxoid material, right? These are the spindle cells, malignant spindle cells, and these are the epithelial cells. Very clear. One slide gives the total picture. Myxoid material, clusters of epithelial cells, malignant spindle cells. Not that of synovial sarcoma. Synovial sarcoma does not look so much malignant, but behaves malignant. But this tumor is ghastly looking. It's a very rapidly growing tumor. So we thought of a pleomorphic sarcoma or a spindle cell, not a spindle cell epithelial mixed sarcomatoid carcinoma or carcinosarcoma, like that we thought of it. Both tumors are there, spindle cell tumor and epithelial cell tumor. We did a biopsy. Biopsy, most of the part is covered by necrosis, extensive necrosis. And these are the areas, and these are the areas. These are the area of the epithelial cells that we have seen in cytology. These are the cells. These are the cells over here. And these are the cells that we see here is over here, is here. So two components are same in the biopsy also as we see in cytology. So in histology we can find these are the cells. Definitely epithelial cells that we found on cytology, and these are the sarcomatoid parts, sarcoma-like area. Absolutely different. So this is really something very tough, and we are very much complex with this. What is the tumor? And we see this is the epithelial nature. Mitotic figures have very rapidly growing epithelial part and very rapidly going sarcomatous part. Both mixed, but intimately mixed. Two components absolutely separate out. Two components absolutely separated out but intimately mixed. And this is the sarcomatoid part. You can see absolutely different from the epithelial component. Plenty of mitotic figures, tumor chances were there. Then we did an IC. IC showed that this epithelial component is positive for A1, that is cytokeratin was positive. And this sarcomatous part, which was looking at, this is necrosis, this is the part is positive for vimentin. So this part is positive for vimentin, this part is positive for cytokeratin. So ultimately diagnosis was carcinosarcoma, yes.
So there are some comments. Neurofibrosarcoma was a differential diagnosis. Sarcomatoid carcinoma, Dr. Neelam Srimani. Pleomorphic
Yes,
adenoma X carcinoma. Epithelioid carcinoma was epithelioid carcinoma. Then epithelial sarcoma. Epithelioid sarcoma was one differential diagnosis. So would you like to discuss this differential diagnosis?
but but
Neurofibrosarcoma.
but see the IC pattern.
Yes, sir.
That gives it, and see this is the morphology. See this morphology is very characteristic.
Yes, sir.
If we find this type of tumor in the breast, what will you tell? If it is in the breast, this type of tumor,
Carcinosarcoma.
yes, you should tell it's a carcinoma because of this sarcomata and carcinoma very well mixed. But only thing is that occurs in the head and neck region.
Right.
This IC helps us. That is not a epithelial component, malignant epithelial component, and malignant sarcomatous component both are there. So that here lies the importance of IC. We should not take that only thing morphology can tell. IC is very important, no doubt, in some cases, without which we cannot give a diagnosis. So the carcinosarcoma involving face, orbit, nasolacrimal duct, and maxillary site. Now, this is really a pleasure to highlight Dr. Pranab Bharma. One day, suddenly in IPM Bihar chapter, he showed us one single case
Sir,
in
may I
lung
interrupt?
tumors.
May I interrupt?
Yes,
There is one
yes, yes.
comment with reference to this case. What is the organ from
What
which
is that?
this carcinosarcoma is arising?
It is a soft tissue tumor. See, this is the tumor.
Okay.
Now I will show you. This is the tumor. And
Okay.
now it has infiltrated
Could it be
this part.
lacrimal also? Is it possible?
The lacrimal gland is usually of epithelial.
Okay, sarcoma wound.
Carcinosarcoma of the lacrimal gland is not so common, but it will not occur.
Okay.
It will in lacrimal gland we can find because of epithelial nature. It is basically a carcinoma, not a sarcoma.
Okay, sir.
And see this is a part where the soft tissue is involved.
Okay,
This
fine.
is the soft tissue, and it has infiltrated down
And
here.
Dr. Verma has highlighted about P40 also. P40 to be done.
P40.
Yes, sir. He has
Why?
highlighted. Dr. Verma says P40 to be done.
For
I'm not sure. I'm not very good in IHC, but he's saying P40 needs to be done. Maybe we'll ask in comment later on. He thinks
okay.
that maybe Dr. Verma can answer in the comment section. If I will read it at the end.
And cytokeratin was positive in these cases,
Yes, sir. Yes.
and vimentin.
Right, sir. Okay. Okay.
In application of cell block in lung tumors, it is very fascinating in what Dr. Pranab has shown in case of Bihar chapter of IPM. And once he first showed us this slide. He told that it is a cell block done from the blood clot. Marvelous. Dr. Sachin, it's a marvelous.
Yes, sir.
A marvelous thing.
Yes,
I
sir.
was really astonished. I was really astonished to how he has made the cell block from the blood clot. by transbronchial needle aspiration. Transbronchial needle aspiration gave very good yield. The cells are in clumps, there are some secretory vacuoles, yes, but he did not throw away the blood clot and he processed the blood clot and see the amount of cells. Very, very beautiful. Only thing we were very happy that this cell block is being carried out also in Bihar. And this is the part we should do. Not only in great institutes are doing, private persons are also doing cell block. That is the importance of Dr. Bharma. And this is a very classical, but no one gives so much importance because they are not fascinated by from cell block. I was very fascinated and asked him, what is the cytology? Then he showed us that this is the cytology. And from cytology, he made a cell block from the blood clot itself. And I told that don't throw away the blood clot. In the blood clot, you can find solid whitish fleshy areas that we also found in angiosarcoma. And he processed the blood clot, and majority, though it is blood, are very glandular epithelial cells with secretory vacuoles were there. And see the biopsy. Biopsy was fragmented. There are columnar cells, there are secretory, but compared to cell block, biopsy was nothing. It was an excellent cell block. So I want to give a thanks to Dr. Pranab, his encouragement to do cell block in Bihar, and he should carry out. And I request him, why not he do a webinar with Dr. Sachin Kalde? He has a good collection.
Yes,
And
sir.
from Bihar, you can get lot of participants. I myself will participate from our state, and will be very proud if we can do. And I have heard his lecture in Ranchi, beautiful lecture of pseudoepitheliomatous hyperplasia, carcinoma in situ, and carcinoma, which are perplexing problems in the oral cavity. And if he can do a seminar with preparation, 1 or 2 months, he may take time. Previously, he was attached to Mohavir Cancer. Now he is doing private practice of himself. He is a very, very methodical pathologist, and I am very happy that he is in here and he is there. So this is an adenocarcinoma assignment type. So thank you very much. And this is the how a cytologist stands. See, precarious condition. I went to Nathula Pass. I took the photograph of this ice chunk. Why? Because this is the position of a cytologist. Very delicately poised. Because if this is not there and this is not here, it will fall. So this is the clinical part, this is the radiology part, and this is the cytology. And how it stands with the help of two, the cytologist stand and can give a diagnosis. So this is the clinician, radiologist, and cytologist who all should join hands to give a proper diagnosis. And this is passion. One should develop the passion. Not only we can see beauty in the nature, but also deep inside the sea. So beautiful is that even the divers go there and scuba divers and they feel fascinating over here. And this is the photography. We should always take photograph of whatever is see the patient radiology. So fascination, passion, all are required for cytologists to develop, and ultimately the real pleasure of clinical cytology and histopathology comes. So thank you very much.
Excellent, sir. Excellent
This is the
presentation. I can give a standing ovation, but I don't know whether others can do it. Others probably are already clapping their hands. Uh,
no, sir. It is my pleasure that all have joined. They have given their diagnosis. They have shared their views. And what more do I want? And you have given the honor. Dr. Sachin, you have given me the honor. And this honor is always behind me, pushing me forward to do webinars. I will
Thank you,
do
sir.
it.
We'll
I
look
will do it
forward to
for you.
future webinars with you also. Now you can stop sharing your screen, and I will just read out few things. Dr. Pradeep Verma says P40 is for sarcomatized squamous cell carcinoma. And there was one question from Dr. Nabanita, where is the epithelial component coming from in a soft tissue sarcoma? Okay, maybe you can answer it later on, or if you want, you can do it right now also.
Now, it is basically a carcinosarcoma.
Okay, fine,
It
fine.
is basically because this slide was shown just to show that sometimes with sarcoma, if we see, we should not miss, there must be some admixture of epithelial elements.
Hmm.
That is the
Okay,
importance.
fine, fine, sir, fine. So everybody is very happy about your presentation, sir. All your cases are, as usual, very well worked up. In the beginning, I said that you are the opening batsman, but now I have to say that you are all rounder. You are
No,
as
no,
good a
no.
clinician as any clinician. You are a good radiologist. You are a good cytologist. Your technique is excellent, and you have given tips about how to perform a better FNAC. what to do, what not to do, what to do if you suspect that blood is going to come, you be gentle about it. Everything, all the hints and tricks and tips you have given. It was a veritable feast of clinical pictures, radiographs. Your radiology is very good, sir. That I think all of us pathologists should learn from you to read good radiographs. So especially thyroid and other things, when we are doing FNACs, that should come to us in handy. Then you have shown lots of good cytology pictures. You have not only stopped at that, you have made cell blocks, you have shared those. Histopathology was there, immunohistochemistry was there, the whole spectrum of pathology of diagnosis of a swelling that can be there. You have shared with us enthusiastically, and it's always pleasure to go through your well-worked cases. I think we can learn lot from you regarding how to properly go about doing the workup of a particular case, documenting it, and not only stopping at that, but sharing with the pathology community with a heart of a gold like yours. I think thank you so
Thank you, sir.
much.
Thank you so much, Sachin. Dr. Sachin, I am really, it is a great pleasure to be with you. Apart more can I say. And I dream to be with you. And
Thank
it
you.
is my,
Thank you, sir. Nabanita is saying Khub Khub Bhalo, sir. She is trying Bengali. Pradeep Sharma is saying thanks. Dr. Manharlal Dadania is saying excellent, sir. Dr. Pranab Verma says cells of origin may be maxillary sinus epithelium regarding that carcinosarcoma. Dr. Verma has given an excellent comment. Cells of origin may be maxillary sinus epithelium also. Dr. Binay
yes.
Kumar is saying excellent webinar, nice cases. Dr. Ashok Prasad is saying excellent presentation, sir. Thank you. Dr. Pranab Verma is thanking you. Manish Jha is saying thank you. Nabanita Das is saying privileged to learn from such a fatherly figure for me. It was so pleasant and educating. Thank you so much. Dr. Shamim is saying, Shamim from Bangladesh is saying wonderful presentation as always. Thank you, sir. Dr. Rajendra Lalani has said excellent. Dr. Mandeep Bedi has said excellent presentation. Dr. Arnab Ghosh, very enlightening lecture. Dr. Manoj
Arnav is from
Kahar.
Nepal. Dr. Arnav is from Pokhara.
Okay, great,
He's from,
great.
he's from Nepal.
Okay, great, great. Good to have you here, sir. And hope to meet you personally when we go trekking in Nepal or you come here in India.
He
Most
often
welcome.
comes to India.
Okay,
He
great.
attends our conference. A very good friend of mine.
Okay, great. Dr. Arnab Ghosh. Dr. Manoj
Yes.
Kahar, excellent. Less in words. Thanks. Thank Dr. Asitava. Dr. So these are all the comments that are coming. Dr. Junu Devi. Ma'am, you also give me your email. Dr. Palash Mondal is saying thanks. Nice, nice cases. So all of you, please later on I will try to contact you, and this is a community gesture that we are learning from each other, and hope we continue to do so even after the pandemic is over, because it's not possible for all of us to leave our places of residence and travel frequently. But through these webinars, it is possible to attend so many conferences without leaving the comfort of our living rooms, and hope this particular sort of bull run for digital pathology content continues as the rally in the share market is continuing. So this rally will also continue. And with this hope, I think it's time for me and Dr. Mondal to say goodbye to you. And Dr. Mondal has promised 2 more lectures in the month of February and in the month of March. We are always looking forward to his lively discussions and interactions. And with this, I think,
Only one comment from my side to
right,
you.
yes, sir, yes.
If I give you the honor of a father of webinars, will you accept it?
It's too big an honor for me, sir. It's very kind of you to say the
No, no,
same
no.
thing. Uh,
We should call you the father of webinars. What is the problem? In Patho India, you are the master.
maybe
I will
I
call
would
you.
say
If no one calls you, I will call you.
okay. Thank you so much, sir.
I
Thank
will
you
call
so
you.
much for that. Basically, it's the need that has arisen for all of us to interact through this particular way. As they say, necessity is the mother of inventions, and this is the particular, not the invention but innovation. Maybe we inspire each other to learn, and hope we continue this thing, sir. And with this, I think
Dr. Sachin, I have one request.
yes, sir.
If 3 or 4 of our friends can do an webinar,
Yes, sir. We can
can
very
you
well.
do it?
We can very well do it, sir. We can very well do it.
Three
Next,
or four of our
yes, sir.
friends
Yes, sir. Yes, sir. We can very well do it, sir. Next
of a
time,
particular particular theme or of their choices.
yes, sir. We
That
can
is a
very well
buffet pattern.
delve
Means
into the
buffet pattern
panel.
means
we can very well include a panel of experts and we can interact through as a panel also, not only just two of us. And we are most
Yes,
it will be nice actually to have a panel together so that discussion is even more lively. Okay,
yes.
so next we'll
Panel
plan.
or three, four speakers, just like a
Definitely, sir.
conference, three, four speakers.
Definitely.
Suppose in a holiday, about 3, 4 hours.
This we can
Each,
do it, sir.
each 45 minutes, four, five speakers.
Yes, sir. We can very
Okay,
well
oh,
do it.
thank you so much.
We will
Then
do it, sir. We will do it.
we'll do a mini conference. We'll
Yes, sir.
term, instead of webinar, we'll term a mini conference.
Definitely, sir. Definitely, we'll plan that. So,
Thank you so much.
Doctor, somebody was asking, I missed it. Somebody was asking whether it can be seen on YouTube again. Yes, it can be seen on YouTube again. It will be there for you to see. So, thank you all of you for joining. And next time also, we want to see you in good numbers. We'll have some different topic the next time. And in the month of February, again, Dr. Asitava Mondal is going to engage with us. And with this, it's good night from me and Dr. Asitava. Good night, take care, sleep well, and have a good Sunday tomorrow. Bye bye.
Thank you so much. Thank you.
Bye bye.